Good morning, everybody. I've made the slide to match what's on the programme, but it wasn't a one-person show, this. Some of my colleagues who also collaborated on this work are in the room. I see Richard Bing there. Helen Lloyd will be coming across a bit more shortly. I think I spotted Amanda, one in the middle distance over there somewhere, and there may be others. So these colleagues deserve a name check. And also in the hope that if I forget or garble something, they can put me right and answer all the difficult questions which you may want to come up with. The other thing I have to say officially, because this is NIHR funded, is that we're only speaking for ourselves here, not for Jeremy Hunt or the Queen or Mrs. Merkel or anyone like that. Right, onwards. Okay, as you know, when the five-year forward view came out, it contained 7 new models of care, one of which were called multi-speciality community providers. The National Institute of Health Research wanted us to gather and review the evidence that was relevant to these, and you'll have immediately spotted the first snag, is that if at that time, as we did, you run a check through the literature on multi-specialty community providers, you come back with precisely 0 hits. So we need a workaround for this. In fact, 2 workarounds. The first one was this, that we don't know yet what MCPs will be like in real life in the UK, but we do know what they are intended to do from the policy documents, and it's all written down there. So essentially, it's some sort of horizontal coordination above all between general practice and community health services, but also depending on the locality and the configuration of services, some combination of the therapies, social care, etc., all those things that you can read there. Now, of course, these are not little local English problems. There's a lot of international interest and activity. You just heard an example in these areas. So we thought that, well, the thing to do here is to look at research on other organisations, other projects elsewhere that are trying to do the things that MCPs are planning to do, including, by the way, some of the work that's going on in Sweden. So that's a bit easier. There's loads of stuff about this, so much so that we had to put in an arbitrary cut-off date to make the volume of work manageable. And so the last, well, by now it's nearly 3 years' worth of studies, gave us 216 to look at, and we limited it to the 22 OECD countries. So we had a setting which was at least, more or less comparable in terms of social and economic development to the UK that we know and love. Okay, and the other thing which you'll find as you go, which you will have spotted already as you go through this literature, is that opinions and plans and models and good ideas and wish lists about care integration are abundant. Hard data on what mechanisms exist, how they work, when they work, why they work, that's a bit thinner on the ground. But so we decided we made the obvious decision to limit ourselves to that. Okay, next thing. A policy is a wish list. So how do you evaluate that? Okay, well, any policy, as the realist will tell you, is a theory. So policymakers are assuming that if you do such and such a list of things, maybe you share medical records, maybe you have person-centred care, maybe you involve the voluntary sector and carers more in looking after patients. If you do those sorts of things, then in the right contexts, what are they? You have to come to that. You'll produce some good outcomes to the ones the policymakers want. So better care integration, cost containment, better patient experience, winning the general election to come, and so on. Okay, so what we do here is, let's try and get this to change, sorry. So we did 3 things here. We elicited the policy assumptions that were in the documents. The documents, as you know, if you try to make sense of them, are always incomplete and vague and sometimes hard to follow. So we also had a number of meetings with local stakeholders in the NHS. Some of you in the room have been involved in this. If so, thank you very much. You're about to see some more of the fruits of this. So we find out what the policy assumptions are, and in a minute I'll show you a little chart which brings them together. You then systematically, I've got a laser I can point. You then systematically review evidences above all about the linkages. So what are the connections between, say, having a patient care plan and earlier discharge? It's the linkages we're interested in, not just the things. And then you can compare them with what the policymakers imagined is going to happen if we have MCPs. So now as always happens when you try and swap formats between different computer systems, the arrows are lost here. There are lots of boxes here, as you can see. Don't worry about the tiny white print. If your eyes are watering, help is at hand. We'll unpack some of this in a minute. What should also be on the slide is a whole bunch of arrows connecting all these, and it's only a slight exaggeration to say that in the way English policy is formulated, it's almost as if everything in this list causes every other thing. So it's a real spider's web of causal connections. So what I'm going to do now is unpick the main dozen or so of these and just go over what the evidence shows about them. Okay, so first thing, Jeremy Hunt can at least be a bit happy because some of these assumptions did have some support in the evidence. So what MCPs are going to be mainly are network coordinating bodies. So you have networks of general practices with community health services in some other organisation, mental health services somewhere else, and so on. And the MCP is going to coordinate them. There is evidence from many countries, but particularly the United States, that these things are actually good for promoting multidisciplinary teamwork, use of IT for health coordination. And in particular, when they create referral networks, it can be effective at diverting patients from from hospital to primary care. Okay, so far so good.
We've lost the speaker back here.
Okay, I'll.
Shout out or shake.
Any better? Can I try and project? Is that all right? Or is that painful? Can you hear me at the back?
Yes.
Perfect. Okay, I'll do it viva voce then. Okay, second thing which the Swedish colleagues mentioned just now is that there is very strong evidence that organisational culture is very important. Changing organisational culture is very important in producing these sorts of changes. I said evidence supported for these points. This was one of the ones which was strongly evidence supported. That means there was both systematic reviews and a number of separate empirical studies to support these claims. So that's clearly important. And similarly, production of care plans for individual patients, very important if you want to bring about diversion of patients from secondary to primary care. That comes out clearly from the literature. Unsupported assumptions. Now, here we need to go carefully. Let's just run through what they are. A lot of UK policy documents talk about demand management, and this seems to mean two things. It seems to mean, in part, setting up referral filtering systems. I mean, there's one in Plymouth, for example, and many other places. And it also seems to mean the effect of somehow diverting patients out of hospital earlier, better, sooner. So there's no evidence, unfortunately, that organisational culture will produce that trick as well, nor that it will necessarily produce voluntary sector involvement, which, as you know, figures very heavily in the policy documents. More, but I didn't expect it, but there we are. That's what the evidence shows. There's no evidence either that preventive clinical care helps divert patients always from secondary to primary care. And to cut a complex story very short, the story seems to be that if you screen patients more systematically, then of course you pick up disease earlier and you can keep those out of hospital. But of course you're also doing more case finding. So you gain some, you lose some, and the two seem in practice to sort of compensate each other more or less. Sorry, maybe that's what you didn't want to hear, but that's how it is. Okay. Then a whole lot of things about where there are conflicting evidence, particularly about the use of IT to manage referrals and to improve the quality of patient care, and also about cost reduction. So what we have here for each of these is a whole bunch of studies that some of which say, well, in these places at these times it worked, at these other places at these other times it didn't work. Okay. So what that's telling us is that the devil is in the detail of the local context. For example, cost savings. Okay, it depends how your hospital's paid. If your hospital is paid, as it is in many European countries and in part in the UK, on a per patient per case basis, HRGs or DRGs, a method like that, then if you divert a patient, there's a question of where the cost savings fall. The commissioner might save money, but of course it's less income for the hospital. And it may be that the primary care services don't necessarily get compensated for that extra work either. So the devil is very much in the detail. If you have block payments, then of course nothing changes, even if you divert financially, even if you do divert patients. Okay, now there were also found a number of mechanisms that the policymakers hadn't thought of, and the two main ones by far were the importance of multidisciplinary teams to produce all these changes in the coordination of primary care, and the importance of IT. Now with IT particularly, I repeat, the devil is in the detail here of the local context, and above all, how the systems are designed. That's very important. But there again, you see saving costs, again, just to illustrate that point, because lots of people are interested. It appears from a few studies that look at this directly that the way IT deployment saves money is not by diverting patients so much as by automating record keeping and record transfer systems which were previously done by hand or on paper or on fax. Anyone here use fax? That quaint system is still, well, there we are. I rest my case. Quaint systems like that are still to be found. Okay, well, look, you can read all this. I won't plod through it point by point. Okay, this one has worked. Now, if you take the original map, strip out the stuff which has no evidential support, add in those extra mechanisms, voila, a new improved logic model for multi-specialty community providers. I'm hoping there's some way we can distribute this to you afterwards, because again, it's a lot to take in visually. Anyway, the main thing is the outcomes over here, got reduced costs, better patient experience, diversion into primary care from hospital, and so on. Anyway, the things that leap out, the other thing to say before I say what leaps out is the thickness of the arrows indicates the strength of evidence. The length of the arrow isn't important. The length of the arrow is just to fit it all on one page. The strength of the arrow indicates the strength of evidence. Okay? So thick arrows, more, better evidence, etc. Now, what leaps out of the page? Well, the first thing is the centrality of multidisciplinary teams, this red box and the corresponding arrows in the middle. If you do the arithmetic, there are 156 different routes in combination from there through to these two black box outcomes. Okay? About 2/3 of these routes go through the mechanism of multidisciplinary teams. Okay, and you'll have seen from the previous slide that they produce a whole range of activities and outcomes, and we'll come back to that in a minute. The next thing is care coordination through IT. Look, by far what the greatest number of studies show is that the importance of IT is to support the work of the multidisciplinary team. Make sure they get that they can share records, make sure they get the prompts and the warnings about how patients are doing, notifications of discharge, getting the tests back to someone who can actually make use of them, etc., etc. I mean, in some ways, it's not rocket science, is it? Not rocket science. And culture is down there as well. Not many arrows, but big arrows, meaning that it's well substantiated. Now, one other thing. Look, two very puny arrows over here at the right. Diversion from primary care into hospital. Okay, sorry, but the evidence that that actually saves cost or improves the quality of patient care is, in the literature we looked, pretty limited. We're talking about less than half a dozen papers for each of those assertions. Nevertheless, there is an arrow, which is better than no arrow, I suppose. Okay, I promised you headline results. Here are three. First, as I said, multidisciplinary teams are seem to be the essential coordination mechanism, but they needed both at group level, in other words, planning the care pathways, the treatment of whole care groups of patients, as well as doing the individual care plans for single persons, individual patients. Second, what matters is the content of the work. So having a meeting for the sake of a meeting is useless, waste of effort. What does produce the value in terms of integration is making clinical work easier and more productive, sharing information, keeping abreast of how the patient's doing, are their circumstances changed, have they been bereaved, something like that. And also the so-called boundary spanning practices. In other words, producing things like shared protocols, shared medical records, which bring the team together in a practical way and help them work as a collective, looking after these patients. Care compacts, by the way, is an Americanism. What it means is that the different organisations and members in the team get together and they agree who's going to do what. So you don't have the duplication of work. You only need one care plan, not two, not zero, just one. Okay. You agreeing that across the groups of people that are involved. The design of IT is critical. The devil is in the detail. So I put it to you that throwing tens of billions of pounds at IBM to sort out your IT system is not the way to go here. That a bottom-up approach, as to be fair to them, general practices have often tended to use in the UK in the past, looks a lot more potentially fruitful. And lastly, sorry, but well, I'm not entirely sorry. I mean, improving patient care is good. As the Russians say, you today, me tomorrow. So this is good, better patient experience. Reducing costs, not yet. Sorry. Okay. There we are. From me enough. Thank you for bearing with it. If anyone's interested, I'm happy to, we can set up some way perhaps by which those charts can be circulated amongst you. Questions, comments, welcome. Thank you very much.